Hi, guys. My name is Dr. Yudara. I'm a consultant emergency physician and CEO of HeHealth. And I'm sure you have noticed everybody is talking about DeepSeek R1. It is mind blowing, and I promise to do some own testing, especially on medical reasoning, because a lot of people talk about all the other things, and I'll focus on medical reasoning. I have used two actual cases, mainly focusing on the diagnosis and diagnostic reasoning, which is my area of interest, and let's see how it perform. Again, names are removed for patient privacy, and most of the details are accurate otherwise. And this gentleman, 32-year-old male, Caucasian software engineer, who I have seen in Singapore, came with severe headache and mild fever for 3 days. And he had photophobia, blocked nose, headache, and which is not usually get better with Panadol. And he had a fall 1 week ago, nothing serious, and also saw a small rash on the both hands, and red small dots, and body aches, joint pains, no travel history, vitals are nothing fancy. He got fever, a little bit tachycardiac, BP is okay, and respiratory is okay, and clinic sign was kind of positive. Bloods were like total whites are high, platelets were okay, hemoglobin was normal, and CT scan had a preview, no major issues, but the final report was pending. And look at this. And it starts thinking just like a doctor. Okay, let me tackle this case. So he goes through the usual details. He's a 32-year-old, and then all the symptoms, and then the interpreting the blood test and CT scans. And then he comes to the magic. First, differentials for headache. He goes through a lot of differentials, the common things, and he tried to connect those things with other symptoms. So if you look at make me think just like a human, it's amazing, and this is the best thing I have seen as a doctor, where I can see full thinking from end to end, not like O1, which doesn't show us. So it really gets me like appreciate how this AI doctor is. And then it comes to then there was this fall 1 week ago. He hits his head, but he was fine. Now with the headache and fever, could this be a subacute complication like subdural hematoma? But CT shows no mass effect or ICH, so maybe that's not it. But maybe post-traumatic infection like meningitis, and if there's seizure leak, but there's no such thing like discharge of rhinorrhea, less likely. And then he goes to the platelets and then try to connect these things with possible diagnosis. And then he goes into things like not so common leptospirosis. It's possible with fever and myalgia and headache, but software engineer, no travel, unlikely. This is how my junior doctors need to think. And then goes to the viral hemorrhagic fever. Given the location and no travel history, unlikely. And then he goes to even things like Rocky Mountain spotted fever, not in Singapore. And then block nose might suggest sinusitis. Is it possible that infection is going from there? And like that, he tried to connect all the dots one by one. Rationalize it very beautiful, just like a doctor and how my junior doctors needs to be. And then he looked at the other angles, like out of the box. The block nose, could that be a red herring, like coincidental URI? That was exactly the case in the actual situation. So there were some red herrings that it kind of push you off the main topic. And then Singapore dengue is very common. So he can actually think like a Singapore doctor in this case. And then he goes into other differentials like dengue related viral meningitis and so on and so forth. He put everything in a very beautiful order, and then he summarizes his findings. Okay, let me put this in sync. Then he come up with this list. Meningococcal meningitis with sepsis, what it supports, and then key considerations. And then he said, look, it looks like bacterial meningitis, but I would consider these things also, which is dengue and then bacterial meningitis from other causes. And leptospirosis is also put in there, and viral meningitis. And then he most importantly said, look, this is an immediate medical emergency. Start empirical antibiotics, ceftriaxone and vancomycins, and do a LP, and then do a dengue test, and then based on the lumbar puncture, you move to the next steps. This is exactly what we did in this case. It's amazing to see how the rationale, the reasoning part comes in. Okay, Let me share another case, which is a little bit more complicated. Again, it's an actual patient who I have seen in the emergency department. And again, names are removed. Rest of the details are more or less accurate. And so this gentleman comes, 41-year-old male, physically very active Chinese property agent, and had a chest pain while practicing karate. He's a very fit guy. He do regular exercises. Never had chest pains before, and previously no known medical problems. When he had the chest pain, it was severe. He had to sit down, no falls, and then after some time, pain got better. But he still called ambulance and comes. And vitals were quite okay. Slightly tachycardic. BP was normal. BP was normal, and breathing rate was okay. Examination rate was quite okay. ECG, there was nothing fancy like ACS or STEMI. Bloods were okay. Troponin was 25, which is borderline, but that doesn't show ACS or anything significant. And chest X-ray was normal. Again, nothing fancy. So, and this case was very tricky because there were a lot of things which is pointing away from the diagnosis, and a lot of people would have missed this case. So let's see how the R1 thinks. Okay, let's try to work on this case step by step. I like it already. So the gentleman is 41, and he go through the details and then list down all the findings. And first consideration, offsets of tearing chest pain, big red flag for aortic dissection. So he get it. Okay, so it's possible that it's dissection, but the problem is pain got improved. Could be misleading. Oh, dissection could have fluctuating symptoms. So that's exactly what my junior doctor thought. Oh, if it's dissection, he should be screaming in pain, and his pain got better. Maybe it's just a muscular skeleton. So, of course, is it possible that it's ACS, but troponin is normal, ECG is normal, you can see, and then I said, but it can be non-STEMI, right? He thinks just like a beautiful trained doctor in this sense. Say, okay, that's possible. And let's go to the pulmonary embolism. He goes through all the other common chest pain things. So like, it's possible, but he's not risk. And then there's no other symptoms connecting. Is it possible that it's pericarditis? It's like musculoskeletal pain. And then he was doing karate. Then he must have done some action and then maybe a muscle tear or something. And GI symptoms like GERD and panic attacks and all these minor things also he considered. A list goes through one by one beautifully. And then he comes to the final things, putting everything and said, look, it's possible that the aortic dissection is the common possible case in this case. And even though the blood pressure is normal, contradictions, even the blood pressure is normal, mediastinal, there's no widening, and so on and so forth. Everything points not to be aortic dissection, but he said, yeah, it's still possible. So, and he points out his things. He said, best to get an urgent CT angiogram because aortic dissection is a surgical emergency. And he said, still, ACS is possible, and then I would still do a ECG repeat and a blood test repeat, PE, MS, musculoskeletal things, and so on and so forth, and possible. Then he gives the next steps, and he rationalizes. And this case, actually, it was a complete tear from aorta all the way up to the carotids and all the way down to the iliacs. So it's a massive aortic dissection. And when we did the bedside ultrasound, we could see the false lumen. And most of my juniors would have missed this case. And I think the rationale and stepwise approach is almost reaching to a consultant level. Okay, now let's take a step back. How does the O1 do it? I tried the same thing with O1. It gets most of it, but it didn't prioritize as the DeepSeek R1 does. And clearly, I cannot see the full rationale and thinking. And this R1 thinks exactly like a doctor. So what it means is this is an open source model. I can take the weights, and whenever it makes a mistake, I can start retraining it to the local settings. And if you are a doctor, if you don't agree with what I said, I think I'm missing a massive part. Yeah, it's going to be very, very smart. So that's it. And I hope you enjoyed. I'll try to share a little bit more about the R1 and all the other AI stuff in medicine soon. Bye.